Hi, Assalamualaikum. My name is Suzana Nabila. I'm from Bachelor of Physiotherapy Cohort 20. Today, I would like to present the effects of mechanical ventilator on digestive system. Before I start, I would like to share a quote by Hippocrates, which is, whenever the art of medicine is loved, there is also a love of humanity. So we, as one of the frontline students, we should be very grateful to be part of humanity. So for my presentation today, topics that will be covered is some background about mechanical ventilator, erosive esophagitis, GI hemorrhage, decreased motility of GI tract, liver and gallbladder, and a bit of summary. So now let's look a bit about mechanical ventilation. Its indication is for respiratory failure, prolonged post-op recovery, altered conscious level, inability to protect the airway, control of ICP in head injury, airway protection following drug overdose, following cardiac arrest, for recovery after prolonged major trauma. So next, the problems during mechanical ventilation included fighting with ventilator because our body system have a protective mechanism that fight foreign things. Next, high airway pressure due to blocked EP tube, high airway pressure due to intrapulmonary factors and sedation factors. Next, erosive esophagitis, which is one of the effects on digestive system due to MV. First, nasogastric or NG tube is a mechanical irritation and interfere normal esophageal motility and sphincter function. And it is a foreign thing from outside into the throat, which is usually the throat has nothing inside, just air and mucus and all. Suddenly there's a foreign thing. Of course, it will trigger protective mechanism in our body. Next, gastroesophageal reflux or GER. This is due to NGQ and it is higher incidence compared to patients who have received MV without the NGQ. Next, supine body position will increase this reflux, which is very dangerous for the lining of the stomach. Next, esophageal mucosal injury. It is because of standard use of stress ulcer prophylaxis makes acid-induced mucosal damage. It is also caused by chemical injury induced by duodenogastroesophageal reflux and direct trauma by the NGQ. Most of the problems on esophagus are due to the nasogastric tube that causing a lot more other side effects, which is one of them GER and esophageal mucosal injury. Next, how do we prevent this from happening? First, put in semi-recumbent position, which is slightly lift up on the upper body for about 45 degrees. Next, NG tubes should be used wisely and judiciously, only when needed. Next, prevent GER and duodeноgastric results by improve gastric emptying strategies. We have to make a strategies to reduce gastric, which is acidic liquid, in the stomach so that it wouldn't be attacking the stomach lining. Next effects of the MV to digestive system is GI hemorrhage. This is due to stress-related mucosal disease, which is progressive compared to the erosive esophagitis, which is lesion progress from superficial erosion to true gastric ulcers. It is tend to be multiple and usually occur in the fundus of stomach, which is the upper part, and later at distal, antral, and duodenal, which is at the end of the stomach, before the small intestinal. Mucosal erosion and or ulcer tend to be deeper and higher incidence of bleeding. Within 24 hours of ICU admission, it is endoscopically detectable, this mucosal erosion. And then generally it is asymptomatic. But if lesion is symptomatic, clinically presentation include occult, overt, or clinically significant bleeding. Overt bleeding may appear as melena or hematogeusia or fine hemorrhage, which compromising hemodynamic. More on SRMD. Erosion of mucosal lesion involve only small vessels, and detectable bleeding does not occur, right? Very rare. However, ulcers will extend beyond the mucosa and into submucosa and muscularis propria, which can erode into larger arteries, which can lead to sepsis, which is a infection of the blood, and can cause MODS, which is multiple organ dysfunction syndrome. Next, the pathophysiology of this SRMD. It is a complex interaction of injuries, gastric luminal factors, which is gastric acid, and pepsin, which is things that we can find in our stomach. Reduced mucosal blood flow due to cardiac input output, reduce intermucosal pH, and impact gastric defense mechanism. As you already know, the lower the pH, the more acidic the chemical. Next, gastric fluid is acidic and it provides enough hydrogen ion to keep causing damage. So since it has impaired the gastric defense mechanism, so the hydrogen ion will keep going, no one will fight them. Next, the reduced stagnant blood flow due to decreased cardiac output causing muscle ischemia contributing to SRMD development. Just like our brain, when there's a ischemia happening, they will cause hypoxia and the tissue will eventually die. So it will causing the organ failing. It also reduces capacity to neutralize hydrogen ions, like I said, and contribute to intramural oxidosis, cell death, and ulceration, which compromise gastric energy metabolism and impair protective process, which is mucus production. As you can see here, this is a picture of difference between erosion and ulcer. Ulcer can extend until muscularis mucosae and submucosal extension, which is more progressive and more dangerous, which can cause bleeding. Meanwhile, erosion, although it's also dangerous, but it's only extend to mucosa. Next, the effect of MV on digestive system. It reduced motility of GI tract. Contractile activity was completely lost in the stomach and diminished to a lesser degree in the duodenum. It causing impairment in gastric emptying with reduced but persistent duodenal activity during empty. As you know, just like our blood supply, it needs muscle contraction to make sure the blood pumps. Same as well as our stomach. The movement of our stomach muscles will move the gastric around and chew our food and eventually will pass to the intestinal and to bowel. So it is very important to have the contractile activity, but in this case, because of the MV effects, it has lost completely. Next, like opiates, dopamine has been shown to impair GI motility, as well as phenothiazine, diltiazem, verapamil, and drugs with anticholinergic side effects. To promote gastric emptying in patients receiving MV, erythromycin, which is one of the antibiotics, should be considered, especially once mechanical obstruction is excluded. Abdominal distension, or also known as most people as bloating, is due to accumulation of substances such as air or gas or fluid causing its expansion. As you can see here, this is a gastric emptying impairment. So the gas will maintain in the stomach, and also not forgetting the contractile activity is completely lost, causing constipation, obstruction of feces, mechanical obstruction, and also eventually will cause abdominal distension. Next, the effect of MV on liver and gallbladder, which is also part of the organ that involved in the digestive system. First, the portal venous and hepatic arterial blood flows and hepatic venous oxygen saturation are reduced in patients receiving PEEP. Positive pressure ventilation with PEP has been shown to elevate portal and hepatic venous pressures causing hepatic congestion. Next, mismatch between the hepatic metabolic demand and the blood supply can result in abnormal liver function. Okay, more on liver and gallbladder. PEP causes liver dysfunction in the presence of hypoxemia, hypotension, or any other condition that further compromises hepatic oxygen supply and that abolishes the hepatic arterial buffer response. Next on gallbladder, acute Alkaloid cholestasis is another effect of MV to digestive system. It is an acute inflammation of the gallbladder in the absence of stones. There is no stones in the gallbladder. However, the inflammation can cause some very progressive damage. Its pathophysiology is related to blood stasis, which is blood pooling, and ischemia of the gallbladder wall, usually related to hypoperfusion, which is lead to local inflammatory response that induces necrosis of the gallbladder wall, which is very dangerous. Its relation to MV is due to decrease in cardiac output. MV redistribute blood away from splenic may affect the gallbladder epithelium directly, causing gallbladder wall to hypoperfusion and ischemia. It also occurs due to prolonged fasting interferes with normal emptying of gallbladder and leads to stagnation of highly concentrated bile in its lumen. As you can see here, this is a ultrasound of the gallbladder, which is the ACC condition. This is the gallbladder. Last but not least, a bit of summary of what I just present. First, the mechanical ventilation, especially the high PEEP, will decrease the cardiac output, which can cause splenic hypoperfusion, and it will causing GI mucosal injury and altered GI motility, and causing a lot of disruptions to the cells, to the functions, some abnormal of the intestinal, and eventually will cause bacteria and toxic transmission and causing MODS, which is multiple organs dysfunction syndrome. That is all for me for effect of MV to digestive system. Thank you so much. Have a nice day.